Hey everybody, welcome to the TIMGA Podcast. Today I'm joined with Dr. Nussbaum and Dr. Fung from the COWIP program, also known as the Colorado Works for International Physicians. Gentlemen, thank you so much for joining the show. Really excited to have you guys here to share some of the successes of the program. A lot of IMGs know about the program already, so I'm sure you guys are getting a lot of responses and emails every year, but just like a little bit of introductions. Dr. Nussbaum, do you want to go first? Just a little bit about yourself and and a little bit about you and Denver Health and how this started from your perspective.
Terrific. Thanks so much for the opportunity. Dr. Fung and I are grateful to be here, and we're thankful for the work that you do and that all international physicians do in the United States. It's a big reminder, over 1 out of 5 doctors in America trained internationally. So American healthcare doesn't exist, can't do the work it does without internationally trained physicians. Dr. Fung and I are grateful to practice in Colorado, but it's a state with a very small population of international physicians. And it also is a state that has a lot of health disparities, a state where most of the healthcare is provided in in the metro areas instead of the rural areas. And it's not a particularly diverse physician workforce. So a couple years ago, I was approached while I was working here at Denver Health in my role as the Chief Education Officer and the DIO for our residencies about a piece of legislation that a local group was trying to run. And the legislation was really built on the Minnesota model. We successfully partnered with the Spring Institute, which was running the legislation, to pass a bill in the Colorado law. And Colorado now requires a 2-step process. One, that there be an agency, like the Spring Institute, that looks at the questions of people with IMGs and sees, are they ready to go to the next step? And then a place that does a clinical readiness program. And the clinical readiness program is designed to help them have experiences in an American healthcare setting that prepare them to match into an American residency. And that's one of the things that's distinct about our model, is that it's in the state law. And 2 is that the goal is really to get somebody into an accredited residency so they can pursue a full board certification here in the United States.
Yeah.
The legislation happened, but there was no funding for it. So nobody was going to run the program. And at the same time, I work here at Denver Health. Dr. Fung works here at Denver Health. We worked together for many years. It's an academic safety net system in downtown Denver. There's one hospital and then multiple federally qualified health centers, and then lots of other services it provides in the community. And one of the things that happens here is every year we bring in a bunch of new interns and residents. And one year, I was trying to get as many of those new interns and residents to sign up for language exams. That in our system, if you can, we want people to provide a language care and a language other than English, and we want them to be certified as being able to do so. So we try to sign up all of our new residents every year to see if they can sign up for a language exam. And one year, the woman who worked for interpretive services and was signing folks up for the exam pulled me aside and she said, "Hey, I'm actually a doctor. I'm here as an interpreter, but I'm actually a physician and I'm triple boarded in my home country. And I would like to be a physician in the United States."
And that's Maria, right? I read your story a little bit on the blog.
Yeah, I wrote the essay that you saw. Did you see that essay?
Yeah, I saw it. Really beautiful piece, and I like how you talked about the camaraderie among students and the foods and people brought, and just an amazing story, like how people, like the tradition that people brought to Denver Health and your team.
Yeah, and I hope you'll share that with the viewers of this podcast and with IMGs broadly. It was a fun essay to write, and Dr. Fung and I are working on some more essays in this area because we'd like to tell people the story about this. But yeah, briefly, it was Maria, right? And she came to me and said, "Hey, I want to be a physician here." I tried to help her. She wrote her application, sent it into the match, and I called friends, and she got 0 interviews.
Mm.
And they said, "Hey, we're not going to interview her because it's been so long since she had American clinical experience." And she'd done all the things and she was working in an American healthcare system and she still couldn't get an interview. So I saw an opportunity and applied for a grant through the Colorado Department of Public Health and Environment and another grant through the Office of New Americans in the Colorado Department of Labor and Environment. And after securing the grant, I also did a project with the AAMC we received funding to run this program for 3 years. And I knew that what we wanted to do was provide a program where we provided people a living wage and health insurance so they could really dedicate themselves to this work, right? And that they could get full clinical experiences. But I also knew that it didn't really help if I, as a psychiatrist, recommended them,
Yeah.
because we were specifically targeting folks who wanted to go into primary care and stay in the state of Colorado, because that's where our funding came from. That's why I called it Colorado Works for International Physicians, because it was workforce funding from the state of Colorado.
Mm.
So I knew that it doesn't help if a psychiatrist says you're ready to go on the internal medicine wards, or a psychiatrist says that you can go into a family medicine clinic. So I thought, I need to find a psychiatrist, a non-psychiatrist, an internist or a primary care doctor who's a great teacher and has a heart for this work. And that's where I invited Dr. Fung to join me as the medical director of COWIP. And he's taken the baton and really run with it and delivered amazing results where 100% of the people in our program have matched.
Yeah. And Dr. Fong, you've been on the show, before. You talked about your story and some of the how you got started and everything. But hey, like when Dr. Nussbaum called you and said, "Hey, do you want this job?" Were you like happy and ecstatic, or were you like, "Oh man, I don't know, I'm too busy. I got a lot of things to do already."
Both, actually. I'm always doing things that seem to make my life busy. But this program was something that I was particularly interested in because I care a lot about physician formation, and not just the transfer of knowledge, but actually how do we form them and how do we make them. And so international medical graduates, in my mind, were a great example of having to do lots of different things simultaneously, because not only were we transferring knowledge of, oh, this is the U.S. healthcare system, these are the tests that are available to you, this is how we think about, insurance, this is how we think about post-acute care, and this is how we think about ancillary services. That's knowledge transfer. But a large part of it was also acculturation, right? Finding out their background experience and their background values, because those are also transmitted in their countries of origin and in the training that they have, as well as coming from them as people, right? Because they are people with values and beliefs about the world and what human flourishing looks like. And so I was just really interested to see, how do we bridge what is always known to sort of be a cultural gap amongst IMGs, because they didn't train in the US, while also trying to give them the clinical experience. And so I was really excited by that possibility, and it's worked out really well. We've had really great clinical experiences, as well as really great conversations with them just about how they see their place in their countries of origin, how they see their place in the US system now, and just where they are in life. And so I think that I really was really excited about doing this, and I'm really glad that it has turned out as well as it has. It has exceeded my wildest expectations, just because it's been amazing. It's just been so much fun, and they've made so much progress, and they have matched. I mean, that's great.
That's amazing. That's amazing. I was so happy when I read your LinkedIn post. Dr. Fong and Dr. Nussbaum, like that was amazing. I was ecstatic. I think a lot of people need to talk about it. And Dr. Fong, we need to go to like ACP in San Francisco and just tell them, hey, we need a room, just to talk about this, and have like a breakout room, because I think a lot of people don't know about this, or like I'm not investing in this. What do you guys? How do you think we can, spread the success and like inform people about, hey, if we invest in like doctors, which is not a lot of investment compared to everything else we do in the country. I mean, it can literally save lives and change our communities. How do we do that?
Well, part of what we're already doing, we've presented some of our work before, but now that we have more outcomes data, we're really trying to push hard to present this at various conferences. We're trying to write things up. We've been meeting we've already started writing, but we need to just finish the writing, put things out there. We've got things written up, or I said we've already got proposals submitted to multiple conferences. And so we're just trying to get the word out there that this works and it's plausible. There is some cost, but it's, like you said, not an excessive cost once you put, when we put everything together. We're looking at getting people into the medical workforce who have, decades of time left to be physicians. They speak multiple languages, sometimes as many as 3 or 4. They're highly motivated. They have, again, cultural insider knowledge to multiple different cultures. We have people from almost every continent now, right? Well, technically, I guess it's Central America, not South America, but I mean,
not Antarctica.
Okay, right, not Antarctica, not Australia.
Zero applicants from Antarctica or Australia.
Right, but we have participants and people who went to medical school in lots of different countries, people from Africa, the Middle East, Asia, and Central America, for 2 years, 3 years rather, 3 years. That's pretty good. I'd like to say that's a broad swath of the type of IMGs that exist in the United States, and that we've shown that we can, even taking people from lots of different places, lots of different cultures, we can bring them up to a place where they're competitive residency applicants and match.
Yeah, I want to just say, I want to tag on to what Phil said, Dr. Fung said. First of all, it's not just that people are matching. At least so far, they've also done well in their residencies, right? So it's not that they matched and then failed out in a month. At least so far, all of our folks are still on track and in residency. So a couple things. You asked the question about how do we tell people this story? Storytelling has to be done lots of different ways. You need data, you need narratives, you need it on LinkedIn, you need it in journal articles, conference posters, and even in a room full of nerds at an ACP conference.
Yeah.
When I've been in, I'm personally not a nerd, but I have also been in small conference rooms at medical conferences. I'm a very, very cool guy, as my kids won't tell you. But what people are surprised about is not only that we're recruiting IMGs, we're recruiting IMGs who aren't getting interviews through the traditional process and often have been an extended period of time out of training.
Yeah.
And the first and most important thing that reflects is the extraordinary resilience of these folks, because they're the ones who are putting themselves forward, daring to make this change in their life and committing to the work and to getting tough feedback.
Yeah.
You know, Dr. Fung's giving them tough feedback of, hey, your write-ups are here and they need to be here. Your patient encounters are here and they need to be here.
Yeah.
So the first credit goes to the folks who are willing to put themselves forward and do this.
Yeah.
But what I would say that we haven't done, but could be done, is to say, look, yes, this program is costs some money, but let's do an analysis of how much it costs versus the economic benefit just to the person and their family, let alone their community, of moving from, say, an interpreter salary to a physician salary. Then let's ask the question about what it means when they're providing care. And at least for us so far, you know, about 75% of the people that we've matched have gone into a rural or underserved setting. And so, you know, it's not just that we're making doctors, it's that we are making doctors who are serving in places that American doctors aren't going as much as they should.
Yeah.
And so I think that if you did a cost benefit analysis, it's going to come out ahead. I also think, and I hope you'll ask us about this, that we think it's a better model than some of the other competition out there.
Yeah, that's amazing, man. I think you guys are, and we'll definitely get to there. You guys are really killing it. But quick question I wanted to ask you is, you mentioned, Dr. Nussbaum, that you guys are taking IMGs who have been out of school maybe like 10, 15 years, or I don't know, longer or shorter, but how did is that right? Is it right?
I don't think we take anybody who's 15 years out.
Okay.
Which is why I winced in the face.
Okay.
And we're not seeking out people who've been a while out from school.
Yeah.
We're just saying, here's the criteria, apply if you meet the criteria.
Okay.
Right. And one of the things that's really helpful that we did in setting up this program is yes, we have a partner in the Spring Institute on the front. We have an admission process. But then we also have a partnership, where we're paying a local group to do an independent evaluation of every learner at the start of the program. And that's incredibly helpful because they're a program that is already doing these kinds of evaluations for physicians, and they're known locally and regarded well. And they've been able to say, look, oftentimes giving people rough feedback of like, yeah, you really are functioning at the level of a first-year med student. Mm. Even though you're a practicing doctor in your home country, it's been a while since you've done this. You're not there yet. And so then that really helps us to go to that person and say, look, here's an objective outsider's view of your clinical skills. you've got to get to the place where you're as at least a fourth-year American med student, ideally an intern. And then we can go to a program and say, look, this person not only did the training, they have this outside evidence that they proved that they improved over the year.
Oh wow, that's amazing. That's amazing. So it just doesn't. That's not the criteria where they're out of school. It's just like, hey, you guys are trying to like give them an objective of here's where you are, here's how we can help you, and etc. Is there an instance? And Dr. Fong, you can answer this as well. Is there an instance where like you guys come across somebody and you say, hey, we don't think that you're right for this program?
Yes. So when we review the applications, we review them all and we bring in most of them for interviews. Some people simply did not. They applied, but they did not meet some of our inclusion criteria, if you will, the basic criteria to even be considered for the program yet. But they were hoping. And so we have had to tell people that, yeah, we don't think that you're the best fit for our program, and that we've had to ask them to, hey. And we have connections where we've told them, hey, we think you should go do this or go do that and get more experience doing this, study this stuff. Maybe you should go for step 3. Other people we thought were ready to apply immediately. And we told them the same thing. We said, actually, you don't need us. You should go ahead and apply for the match right now. Get your letters from these people. You're already doing research in our system. Like, people know you. You could get a letter from this person. You're only a couple of years out from your last clinical practice in your home country. Your skills should be sharp enough that you could, step into residency and take care of patients. And so we're trying to make sure that we point people in the right direction when they come to us, even if we're not accepting them into our particular program. And so we have done that. We've said, you should go over here, you should do this. And so we've had some pretty good feedback on that front as well, where we had one of the persons we said, you should go ahead and apply. They did apply, and they actually matched on their own without our program.
Wow, that's amazing. That's amazing. So, and congratulations first on your first cohort. Is this is the first cohort that's matched, right? Or is it?
No, this is our second cohort.
Second cohort. Oh, nice. Second cohort that matched. Tell me about for year compared to year 1 versus year 2. Do you guys see a development in the program itself, like getting better? Or maybe having better outcomes, or is it the same? And are you guys kind of like riding that wave of success?
I don't think we're riding the wave of success, right? I think our learners are riding the wave of success, right? I just had my lunch down the hall, and 2 of our learners were there warming up their lunches, and I talked to them about all their clinical experiences, and they're the ones doing this. But absolutely, the program's changed and grown year to year. And I think we've learned a ton from doing so. Dr. Fung's been the one really leading that, kind of the day-to-day operations. So I'll turn it over to him to explain how.
Yeah, so the biggest thing that we learned, I think, is that because we only have so much time with these learners, that there is sort of a sweet spot for how long they've been out of clinical practice that we can sort of get the most benefit out of their time with us. And so, like I said, there's some people who apply to our program. We're like, you should just go ahead and apply now. You're like 1.5 years out from your last clinical practice. You've been doing research here. You know people. You can get letters. Go apply. Other people were, last practice 20 years ago. And I'm like, I don't know that I can get you up to, US speed if you haven't done any clinical medicine in 15, 20 years. That's a hard ask. Doesn't mean that they can't ever be residency ready. It's just, I don't know that I can do it in the 9 months with the resources that I have. The people that we have found that seem to have the most success, again, we've only had 2 cohorts, so a total of 8 people who have matched. Seem to have the most success are the people who have had some independent practice experience within about 5 to 8 years. It depends on the person. It depends on their experience. And what have they been doing in the meantime? And so one of the individuals who matched this year, this past March, had been out of medicine a little bit longer, but had stayed involved in the medical system in a number of different roles, on the research side, on the patient-facing side, just not officially doing clinical care. And so his experience in all sorts of aspects of the healthcare system kept him up to speed on terminology, on the system, on things like that. And so that allowed him to stay sort of involved and still exposed to medicine, if you will. And so that's what we're finding out, is that it really has to do with the success of the program. Really has a lot less to do with us, we feel like, as in it really has more to do with the applicants and the participants. And when they come to us, they are already been preparing themselves for some time, but then they have a great baseline foundation of just knowledge and experience. And when they step into the clinical experience that we give them, they're just ready to run. The other thing that's really been helpful for us that we've learned as a program is we've really tried to this year put a lot more emphasis on individualized learning plans. We did some the first cohort. We've really been pushing it for this second group that just matched, and we got lots of great feedback that they really appreciated when we took that external assessment, helped them build sort of learning plans. We got monthly feedback from various preceptors, kept on trying to integrate that and say, okay, well, this month we're going to work on this. This month we're going to work on that. The mentorship that we provide through my colleagues who are the preceptors has been, I think, exceptional. And that I really am not responsible for. That really is the work of my assistant medical director, Dr. Jha, who is one of our family medicine faculty, who is extraordinarily capable and excellent at medical education, things like individualized learning plans and really getting mentors to sort of take evaluations and help the learners with the partnership of their mentors really come up with discrete, achievable, measurable goals that they then can be evaluated on an ongoing basis by us to see the improvement and growth. And I think that feeds back when they see their success, when they see that they're able to do things, they feel like they can continue to make progress. And I think it's proven to be true. They are exceptionally driven and dedicated and hardworking people who really are the successful point of the program.
That's amazing. That's amazing. And one thing that I liked that you said, Dr. Nussbaum, was, hey, it's not only about doing the program, like our trainees are doing well in residency as well. Like they're continuing residency and they're doing well in residency. So what's the percent of doctors, IMG doctors, you guys were able to place in Colorado versus like the other places in the match?
Yep. So we have 8 people who've gone through the program, and our goal was to get everybody to stay in Colorado, but there's no way that we can require it. And we've gotten 7 out of 8.
Wow.
So, I mean, yeah. I feel pretty good about
That's
that.
That's amazing. Yeah.
Dr. Funk is smarter than me. I'm okay with taking a B+.
Yeah.
Right.
That's an A. That's an A right there.
It's a B+. It's a B+. I'm a psychiatrist. I know you internists are sticklers for specific statistics, but so far 7 out of 8 have matched in Colorado, and we're really excited about that. We love our state and want to see anything we can do to improve its healthcare workforce.
Yeah, Dr. Fong, what do you feel about 90%? I think it's great.
Like I said, this has been wonderful. We have been nothing but exceedingly happy for our participants. Our partners in the state are very, very happy, just on behalf of the international medical graduates, but also to see that the program works. Right? They like to see that the money that they have given us is working to produce some of the things that all the things, basically almost everything that we had hoped for. Yeah. So 7 out of 8 matched in primary care residencies in the state of Colorado. And again, these people have already got roots here. They wanted to stay. Many of them, all of them wanted to stay in Colorado because this is where their home is. This is where their family and their friends are. And so they're very glad to have matched in the state.
Did you guys have to do any outreach to program directors in Colorado and say, hey, like, these are our candidates coming. They are trained. Here's what they kind of do. Here's how we prepare them. So, like they can kind of be unfiltered, because I know like in the MASH system, there is like a filter process. Even though somebody's great, their years out of school might kind of like take them out.
Yeah, that's exactly what I did both years. So I reached out to all the program directors in family medicine and internal medicine across the state, both years, and explained our situation. And I've been to various meetings. There's actually a Colorado Association of Family Medicine Residency Program Directors that I have gone to their meetings, and I've met with them in person to discuss what the program is, who they are, give them their names. And there's been great feedback from the program directors where they will say, yes, absolutely, we will pull their name and we will review their applications very specifically and not let it get filtered out. And so that those connections and those relationships have actually borne, I think, a lot of the fruit that we see because they took the time to look at their applications and brought people in for interviews. So that is exactly how we did it. I did not reach out to any programs out of the state since, our primary goal was to keep people in the state.
That is amazing. I mean, that's something that, you guys can say, hey, the Colorado tax dollars that, you put into this are actually gonna, serve the people in Colorado, which is, it makes sense. Like when you're, advocating, you can just point to these numbers and say, hey, like, this is working, and I know in Minnesota, they had a huge problem. They had a similar, program like you guys, but everybody was going out of, the state of Minnesota. And, it was kind of, it was a problem to justify that. But you guys kind of like learned. I think you guys learned from that and kind of added a few steps to it. So congratulations on that, Dr. Nussbaum. Back to the question I wanted to ask you is, your program versus all the other models that are going around the country. There is this conversation about, hey, everybody wants to do what Colorado is doing, but like nobody's willing to pay for it long term. So a lot of people are kind of like doing different type of programs where they're issuing licenses or doing some kind of alternative route. So what do you feel? How do you answer that question first about funding and the sustainability of the program and your model compared to everybody else's?
You can put a price on patient safety. And this is the key thing. The reason why the residency system exists is to protect patients. The reason why it takes a while to develop a physician is to have experience under a supervised setting where you meet standardized competencies. So that when Dr. Fung or myself have gone through an accredited residency and people can know and be sure that we've had a sufficient amount of supervision and a sufficient number of experiences to be at least competent. That sounds like a low bar, but it's a big deal to be competent in the care of someone else's health. When a physician is inadequately or poorly trained, it causes harms to patients. Many of the alternative pathway models are quick fixes. They're good in the sense that they get people back into the workforce, but they're bad in two ways. One is that they eliminate a lot of the pathways that make sure that people have adequate supervision and safe training. And two is that for the IMG learner, they don't give them the full benefits of being a board eligible or board certified American physician.
That's true.
If somebody goes through a program like this, they're entering into an ACGME accredited residency. If they do well in that residency and graduate, they'll be able to sit for licensure just like myself or Dr. Fung, who trained here in the United States, and then they're eligible for all kinds of jobs. A hospital like ours won't hire you if you're not board eligible or board certified. Most hospitals are that way. It's a short fix for a long career. An average physician might be able to work 10, 20, 30, 40, even 50 years post-residency. And so it can seem like a good thing to get them into the workforce today. But if they then aren't able over those 10, 20, 30, 40, 50 years to be able to choose where and how to practice, that's really not the full job of being an American physician. It's also not the full training, which is really designed to make sure that we have safe, competent physicians in the United States.
Yep. And then, Dr. Fung, I know you answered this in detail on the last podcast, but do you want to recap your thoughts on that?
Yeah, I agree with Dr. Nussbaum that basically the other thing that I think that we are a little concerned about for some of these alternative pathways is that the way they're constructed, there could be extreme variability in their supervision and their education. It is not always clear in these pathways who is going to be doing the training, how much are they going to experience of various things before they've sort of made it through the pathway, things like that. I do know that some of the alternative pathways do provide for external assessment, which we agree is a really good thing to include, because you do need somebody outside of the program to evaluate them as well, as a relatively more objective observer. The other thing that also concerns me is that when people go through the alternative pathway, that may have a stigma attached to them as not being as well trained. as someone who went through residency. And again, that doesn't necessarily mean they're a bad doctor. It just they have not gone through the rigor of residency, the same held to the same standards and things like that, because it is an alternative pathway. And so that's something that I do think is perhaps not doing the IMG a favor if they may already be facing bias and stigma in the wider world, if they are also seen as somehow less well trained.
Yeah, I agree, because I think right now, especially around the country, is the wild west of alternative pathway. You'll see some alternative pathways that have like a kind of like a PA model, and you'll see kind of that kind of work under the supervision of physicians. Some that have like a different model. So it's kind of like there's no standardized alternative pathway out there. So it's every state kind of have like their own thing.
And to be clear, we're not proposing an alternative pathway, right? We're trying to get people into the regular pathway, right? I mean, because we want people to have the full training of an American physician and the full opportunity. So COWIP is not a replacement for residency, right? COWIP is an entry point. It's a door. That's our job, is to say to people whose doors keep on been closing for, that we're going to open a door for you. That's it.
Yep.
But then the goal is they get a walk through. They're the ones who have already trained as a physician, and they're the one who wants to bring forward their skills and abilities. We're just opening doors for folks.
Yeah, and I agree. Hey, look, I personally, I believe the COWIP program is probably the best program in the country if it can be sustainable. Because like my question is, look, I think it's amazing because you guys are like paying people, right? You guys are paying people to study and be a part of this. They're getting into residency, they're getting everything. Because like, why go through an alternative pathway when you can get 1 year of COWIP and have an amazing success, amazing chance to match, and a 100% chance to match according to the COWIP program. But but I really, the question is, how do we like make it sustainable? Because like there hasn't been, like, in my opinion, like I've spoken to a lot of legislators, a lot of federal leaders. I've been advocating on this for a long time, and I don't see the political will when it comes to funding a program like a COWIP program long term. Everybody's like, "Hey, we're already funding residency, which is cost too much. Why add like another additional year?" So, how do we convince the political system to change this?
Good question. I like to tell people that the American medical education system is the original sin of the American healthcare system. It's very costly, but we're not dedicating the funds towards community needs. There are awesome colleagues of Dr. Fung and I who are in specialties. I won't name them, but you can figure them out on your own, that are awesome, but that there's a market-based solution for them.
Yeah.
American medical education is subsidized by the taxpayers of America, through Medicare taxes especially. That ought to be dedicated towards helping people into medical specialties which otherwise aren't filling at the rates we want to. That means things like primary care, pediatrics, psychiatry, general surgery, OB-GYN. Even, God bless them, internal medicine, right? Especially GIM programs, family medicine. Those are the programs. And so one thing to do is, like, you can join a group like GME Transformation that's focused on driving community change and speaking to legislators about how to do it. Every legislation in the country knows that healthcare costs have gotten too expensive, and you've got to raise this forward as a way to cut costs, right? Take the money you got now and direct it better towards community needs.
Yeah. And Dr. Musbam, do you think, and Dr. Phil, Dr. Phil Fung, you can answer this question as well. Do you think maybe it's also not a priority for, powerful medical societies around the country who represent physicians that, hey, maybe this is an important issue? Do you think it's not included in most legislative priorities?
I don't think that people, I don't know the answer to that question. There's lots of different medical specialties and societies. I would say that the evidence is that after decades of stasis, there's a ton of stuff going on in this space. So people have cued in that something's going on with IMGs, and people are trying different things in the legislature. You're right. Not a lot of them are trying the high quality, door that we're trying to offer through COWIP. But I do think it's a time, I try to be optimistic. I think it's a time of change, and people are looking for alternatives. If you belong to a medical society, you could ask them to, hey, what are you doing today to try to help your fellow physicians who trained elsewhere? I do think they could do more, but I don't know. There's a lot of different societies and specialties.
Dr. Fong, your thoughts?
One thing that I would say is that, especially in the primary care specialties, it's not like these IMGs are taking spots away from American graduates,
Yeah.
right? Family medicine doesn't fully match every year, so it's not like these folks are taking away spots that these societies may feel they have to protect, if you will, for U.S. graduates. I think that there's a lot of space to take highly qualified IMGs, not just everyone, but the people you have to make sure that they're ready, but to take highly qualified IMGs to residency and give them every opportunity that a U.S. grad has. And I think that there's good incentive and good reason to think that these folks will be able to get into the healthcare system in a way that also doesn't have that same pool to pay back loans, especially now that medical schools have gotten so expensive. We know that part of the choice that U.S. graduates, part of what they take into account when they make their choice of specialty is their student loan burden. And if you're taking some people going into residency who don't have that same loan burden, that changes what they will consider as a specialty and also how they decide to practice in the future. I think there's pretty good evidence that is a factor. And so if the medical societies are interested in making sure that there are more people doing primary care and things like that, I think that it's good to look at international medical graduates as one of the potential sources of getting well-trained physicians into the U.S. workforce to meet that need in the country.
Yeah. Nevertheless, go ahead.
It's not an either or, right? IMGs are not, as Dr. Fung said, they're not trying to take away doctors from American physicians. It's a how do we serve community needs, and both are part of the solution.
Yeah. But nevertheless, there's 100% match success rate. That is amazing. That should be like the headline of every newspaper in America. Dr. Nussbaum, you got to give Dr. Phil Fung a raise, because I think a lot of other states are going to call him.
Yeah, fair enough. From your lips to our chief finance officer's ears. I don't know what Dr. Fung would say, but I think he would say yes to a raise.
Yes, I would say yes to a raise.
Yes.
But I'm just glad that I had this opportunity, because we're not sure what the future holds, and we do need to find a way to make these programs like this sustainable, as you mentioned.
Yeah.
Because I don't. You're right. The relative, the interest is there. The commitment is perhaps not as easy to find.
Yeah. Let's talk about that before we hop off. So where do you guys, Dr. Nussbaum, where do you see this program heading in the next couple of years? Has there been conversations extended? What is your over thoughts about this?
We have, all of our community partners have loved this program. Right, the Colorado Department of Public Health and Environment, the Office of New Americans have given us great feedback. The Colorado Department of Labor and Environment, right, they love it. Spring Institute, our trainees are great. We've had great feedback from our hospital and clinicians. We are trying to figure out how to sustain it now that our grant is running out. And so we had a workforce grant to do this, some ARPA funds, and we're trying to develop a business plan. I'm not confident we're going to be running this a year from now. But I am confident that we're going to learn from it, and we're going to keep looking for opportunities to do it. And we're going to explore this and other ways of trying to get people there, because we've demonstrated that it can be done. But it's, as you've said, it's a challenge right now to get funding. But we're going to keep trying.
Yeah. Everywhere, is a challenge to get funding. I've been experiencing that firsthand for some of the basic programs that we used to do, like, for example, paying for like USMLE stipends and there's some basic books, and we used to do, even that's kind of hard to get these days. So it has been a challenge, but I think, there's better days ahead for sure. And I think you guys can definitely, restart this program in the future.
We'll see. We haven't shut it down yet. So we've got a group training right now, and every class is great, but this one seems like an especially good one. And we're really excited. We're going to help this group all the way through the match next year. And I bet we'll be here a year from now, posting on LinkedIn and other places, telling people that we were successful again. I believe in the 4 people who are training with us right now.
That's amazing. And hopefully you guys will hop on the podcast again and share those success stories. But before we hop off, any last advice to other program administrators out there who are trying to do this?
Hire somebody like Dr. Fung. We also have a terrific young woman named Susana Portillo, who really runs the program on a day-to-day basis. I think, having buy-in from lots of different community forces has been really helpful. But at the end of the day, you're trying to support someone else's dream and help them through the door. So I think all the ultimate credit goes to our learners themselves.
Dr. Fung?
Yeah, I agree. I've had great people around me. I never could have done this without Susanna, without Dr. Jha, without all of our preceptors. We've just had really great faculty who are really interested in seeing this program succeed, and most of all, to see our learners see their dream realized. And I think that motivation is a huge part of what makes things work for our program. And so I really would say find really good people, and that will go far.
Dr. Abraham Nussbaum, Chief Education Officer at Denver Health, founder of the COWIP program, and Dr. Phil Fung, Medical Director of the COWIP program. Gentlemen, thank you so much for coming on the podcast. I'm really excited to spread, your success and talk about it everywhere I go. And hopefully, you guys can come back on the podcast again with another 100%, like maintaining that 100%. Success rate.
We want to keep, as people used to say, it's now outdated slang. We would like to keep it 100.
Yeah. Awesome. Well, hey,
thank you.
If somebody wants to reach out to you guys, can they, are you guys on LinkedIn, or how can they reach out to you guys?
They can reach out on LinkedIn. They can read the article I posted last month in the magazine Virtues and Vocations at the Institute for Social Concerns. We also have a website. They Google Denver Health and COWIP. Put in Denver Health and COWIP, and they'll get to us.
And we'll kind of include a link to the essay in the show notes as well. So thanks, gentlemen, again, and we look forward to seeing you soon.
Thank you so much for
Thanks
the work.
for having us.